It is my pleasure now to welcome Professor François Venter. Professor Venter is the Divisional Director of Enzisha at the University of Witwatersrand in Johannesburg. His interests are in the public health access to services, and his work involves health systems research. He leads multiple antiretroviral treatment optimization and is currently working on new first and second line ARV options, and I'm sure most of us are familiar with his name. He has led large PEPFAR-funded programs in South Africa. He's also an advisor to both international and local organizations, technically, including UNAIDS, WHO, as well as the South African Clinicians Society. We are privileged to have him with us, still talking on this subject that I think our interests are now being raised on. His topic is dual regimen. Is that the future for Africa? Professor Venter.
Thank you. Thanks, everybody, and thanks for the invitation. It's great to be back in person at the Interest Workshop, and it's great to be talking to clinicians. So, and thanks to Michelle Venter. For everyone, despite the uncanny resemblance, I'm actually not related to Michelle. Venter's a bit like Smith in South Africa. It's a very, very common surname. And Michelle's done an amazing job of talking through the various studies and things around dual regimens. And as she said, it's an evolving area, and because the drugs have just got steadily more powerful, it's become more of an option as we've just got new drugs, more powerful drugs, drugs with a greater resistance profile coming into as an option for us. So I'm going to take you through this and just talk about what the implications are for Africa. I initially was quite dismissive of these drugs and of dual regimens in general. And I'm going to talk about the complexity, and just the complexity of the last few months that have evolved around dual regimens, and why we do need to be taking it quite seriously as Africans for the region, both from a cost and from a practical perspective. And I'm not quite sure what happened there. Oh, good. These are my various disclosures. We are doing some research work on these various drugs. So what have been the great leaps forward for us as Africans in terms of antiretrovirals? Well, the first one really was the development of triple therapy. We didn't have dual therapy like the rich countries did. We didn't go through AZT, 3TC for treatment. You know, we had some of these dual regimens for PMT-CT, but we didn't really go through those convoluted, mono and dual therapy cycling. We went straight into triple therapy in the early 2002, 2003, 2004 period, initially with stavudine-based regimens, then we moved into tenofovir and nevirapine, efavirenz, and then more recently into dolutegravir. Other big leaps were the use of efavirenz replacing nevirapine. Many of us used triple therapy with nevirapine. Efavirenz was a big leap forward. Nevirapine was difficult to use because of the doubling of the dose over the first few weeks, the side effects associated with nevirapine. The use in rich countries of efavirenz replacing protease inhibitors was a big leap forward. For us, having access to protease inhibitors in second and third line was a leap forward. And then in sort of around 2010, the use of tenofovir replacing stavudine, as we saw the mass toxicity with stavudine, the lipoatrophy in particular was a nightmare. Those of us who saw lactic acidosis will never forget that. So that was great. And then finally, dolutegravir has really transformed it. And I think because of COVID, as dolutegravir sort of came into use in 2019, we haven't really had time to really reflect on it much. And the drama of COVID has meant that we haven't really looked at it. But dolutegravir really has changed the world as it's replaced efavirenz. And I think there's time to start looking at it now as things are starting to settle down. For those of you who are interested in new drugs and some of the stuff I'm going to be talking about, this HIV pipeline report, which comes out every year, is run by activists, is a great place to look for the new drugs. First, the ones that are coming, the ones that are being researched at the moment. Not just HIV, it's also hepatitis C, hepatitis B, the new diagnostics, but they're great. It's run by activists, not by the drug companies, and the activists just phone up the drug companies, the CEO, and say, what's happening with this drug, what's going on? And it's just a really useful resource. Like all the big researchers use this as the place to go to get updated on what's happening, what's secret, what's being developed. So it's completely free, available as an PDF. It's just a shout out to these people who do it for free. In terms of the great leaps forward, I think we need to say that the first-line oral combination of tenofovir, 3TC, dolutegravir, some of you are using TAF instead of tenofovir, and we'll touch on that a little bit. That really has been the great leap forward. And we need to acknowledge the fact that the bar is pretty amazing, and it's going to be hard to improve on that. And there's some data that's going to be coming out in the next few weeks that will maybe muddle this a little bit. I can't talk about too much more about this. But the oral integrase inhibitors, the second generation integrase inhibitors, dolutegravir is the one most of us are using. In rich countries, bictegravir, there's very little to choose between the two drugs. Has set the bar at an unbelievably high level. It's actually quite hard to think of a way in which we're going to improve on this oral combination. The resistance barrier is almost unbreakable, and we're going to hear that in the next talk we're going to be listening to that, but we still only have a handful of patients who've broken dolutegravir, and it's really been in the context of previous exposure to raltegravir. At the public health level, we're still not seeing patients who are able to break first-line dolutegravir-based or bictegravir-based regimens. And you have to understand that this is in the context of tens of millions of people being exposed to it for years now. In some places like Canada, they've been using these drugs for over a decade, and they still haven't properly demonstrated a failure to first-line therapy. So when people say it's coming, it's coming, it's coming, it's been a long time coming. So it might come, but we haven't seen it yet. And it took quite a short time for us to break Alluvia. It took a year or two. And people were saying it's coming and coming. It did come, but we still haven't properly broken the protease inhibitors at scale. And with dolutegravir and these second generation integrase inhibitors, we're taking a long time to get there. So there's still a debate as to how big a problem public health, at a public health level, we are going to see resistance becoming a public health problem to the second generation integrase inhibitors. So just keep that in the back of your head. It's also incredibly well tolerated. I don't know about you guys, but we still battle to have patients who don't tolerate dolutegravir, or bictegravir for that matter. There are patients who occasionally have insomnia issues, who occasionally don't tolerate it from a CNS perspective. But even with those, with a little bit of counseling, most of them get over it. We've made our peace with the fact that dolutegravir does not actually make you gain weight. And once we've got past that, really these patients are incredibly well tolerated. Even with patients who have very low thresholds for side effects, which are often the European and American patients. When I talk to my colleagues there, I ask them, when do you use doravirine? They say, oh, it's when our patients don't tolerate dolutegravir or bictegravir. And I say, how often is that? And they say, oh, very, very, very occasionally. So even with very fussy patients, it's really not that common. Now, I'd be interested to hear your own clinical experience with these drugs. There are extremely limited drug-drug interactions with the second-generation integrase inhibitors, and they're largely around metformin, where all you do is just dose-reduce the metformin. And importantly, it's not with hormonal contraception, which was a real issue with efavirenz. So again, we really have been gifted this class of drugs, which are generally very well tolerated in general practice. So you don't have to sit worrying about common drug-drug interactions, which was a real problem with efavirenz and a very big problem with the protease inhibitors. And finally, they were cheap. In fact, dolutegravir was cheaper than efavirenz to manufacture because of small milligram dosage. The tablets are smaller, the packaging is smaller. So we got a much better drug with a bigger resistance barrier, which is better tolerated, and it was cheaper. So in many ways, dolutegravir came as a real gift to Africa in so many ways. So again, we got this amazing combination, and to better it is going to take a lot. So we got this initial wave of dual therapies, and Michelle's summarized them beautifully, so I'm not going to bore you with going through the data. A lot of them were approved in high-income countries, and some of them have had some utility in our context. And certainly where I've been working, the place for dual therapy is where we managed to drop the tenofovir, mainly in the renal patients, knowing that you can use dolutegravir and 3TC by itself very safely, and Michelle's gone through that data amazingly. Is being able to say in a renal patient, we don't need a bacavir, which is expensive, it's got its own fiddly bits about it, it's quite difficult actually to access, particularly in the public sector for us, that you can use dolutegravir 3TC by itself, just dump the tenofovir. We would have liked to use TAF, but again, it's expensive in our context. You can dose reduce tenofovir, but it's fiddly. Just dump the tenofovir. So being able to do that has been really, really useful. There's been difficulty in our situation with using the combination, as I said, because of the cost of using this dual therapy, which is only available through the drug company. We can use the two drugs by themselves and just administer them. The patients are fine with that. You do lose the hepatitis B cover, which we'll touch on in just a moment. We have this drug called Juluca, the combination of dolutegravir and rilpivirine, which is available, again, for switch patients. Very, very good combination, but again, TLD is very, very good as well. So why would you switch from one very good regimen to another regimen that's very, very good and lose the hepatitis B cover? And then we've now got the injectables coming in. I'm going to spend a little bit of time. And when people are talking about dual therapy and TLD, I was like, why are we that interested in dual therapy? Why talk about dropping the tenofovir and dropping the TAF when we're going to have dual therapy soon anyway? It's going to be injectables. Not this combination. I think particularly the rilpivirine is not very friendly. The cabotegravir is pretty good, but in combination with new drugs that are on their way. And we saw all these new drugs, these new injectables, islatravir, lenacapavir, some of the other drugs, they're all on their way. Soon we're going to have dual injectables coming. Let's leave TLD for the moment. It's one tablet once a day. It's cheap, it's friendly, it's amazing. Let's leave it alone. I'm going to talk a little bit at the end of the lecture why actually the last few weeks I've started to think maybe we need to think hard about this going forward. The combination of rilpivirine and cabotegravir is fiddly, and it's given us 2 separate injections. It's probably going to be, I'll show you why it's going to be quite expensive. It has to be given by a nurse or a trained healthcare practitioner. You can't get the patients to give them by themselves, even if you train them, because it's really difficult. You have to give it in 2 different places in the buttocks. It's just a pain in the neck. The rilpivirine needs a cold chain. So as dual injections go, this combination, this dual combination is not very friendly, particularly in our context. And the immediate issue is the hepatitis B. All the dual combinations, once you lose the tenofovir or the TAF, you don't cover hepatitis B. Now, in our context, that is not a great combination. I'll talk about the operational issues in more detail in terms of the injectables. Now, you need to understand that the injectables are on their way, and sometimes I think in Africa we think, okay, it's coming down years. Every time these new drugs are coming, dolutegravir, when it came to tenofovir, it took us 8-9 years before we got it. Dolutegravir was fast. It took 3 or 4 years before we got it. We need to anticipate that these drugs are going to come into our programs much, much faster than in the past. And this goes for the injectables. And these are just some of the drugs. You'll see some of them you can recognize, old drugs that are now injectable drugs. Some of these drugs are going to be made available much, much faster for us than we previously used to. And we need to start thinking about how we're going to implement injectable drugs into our programs. And there is the possibility that there'll be dual oral drugs as well coming into the programs going forward. Some of these long-acting drugs are not just injectable. Some of these long-acting things are not just injectable. Some of them are oral. A drug like islatravir you can actually give once monthly as an oral tablet. Or as a weekly tablet. So we need to start thinking more creatively as we're going forward is how are we going to accommodate some of these dual therapies, triple therapies that are just going to be much more long-acting than in the past. And some of these drugs do offer resistance and cost benefits. Most of these drugs are the initial studies, as most studies do with these drugs, they look very, very well tolerated. They often have a couple of months data, and the drugs are offered to in phase 1 and 2 studies to the patients. The patients tolerate them very, very well. You have to do studies over many months and years before you can see the true toxicity of the drugs. But the initial data on all those drugs I was showing you there is pretty good. We still need to see the resistance barriers, but again, the resistance barriers are looking pretty good. Whether it stands up, we'll see. And I'll talk about the islatravir and the lenacapavir studies in just a moment. The drug companies, by and large, are demonstrating that they are cooperating with the generic companies, the innovator companies, and they've started to engage with them. And we're seeing it with some of the companies are already talking to them about making the patents available as going forward. So hopefully these drugs will be available at scale to us at a reasonable cost. So suddenly we've got these new leap forward, and it's amazing to think about. Rather than imagine you've got a monthly tablet. So you're not giving them, I don't know, 180 tablets, so 6 months of like tubs of tablets. You give them a single tablet, 6 months, 6 monthly, and that actually is a possibility for both PrEP and for treatment going forward. Even if it's for weekly, you might be giving them 24 tablets. You could just give them a single tablet tub for 6 months. For the injectables, it might be very similar to some of the injectable contraception, where you're giving injections every 2, 3, possibly every 6 months. With islatravir, they're looking at an annual implant. So the world is changing very quickly with these long-acting formulations, both oral and the injectables and the implantables. So when we're looking at this, we always think about, how is it for women, and particularly in the context of pregnancy, but also for women in general, is their safety? Because these drugs tend to be tested mainly on white men in North America and Europe. So are they tested in women in Southern Africa? Hepatitis B, and TB, then there are the programmatic issues. Can you do this in places where healthcare systems are weak, which is almost all our countries in sub-Saharan Africa and Southern Africa? And then the issue of cost is obviously a huge issue for all of us. So it's important always to keep in the back of your mind, women are the majority of our programs in our area. In Southern Africa, and it seems like the rest of the world just conveniently forgets this all the time when they're developing these drugs. And then they wake up like 4 years into the program and they're like, oh yeah, women are actually humans as well. And then have to deal with issues around the fact that they, some of the toxicities specifically seen in women, which we saw with obesity development in terms of TAF and dolutegravir. And then the issues of pregnancy and teratogenicity and PMTCT and all of those things, almost an afterthought when they're developing these new drugs. They're almost universally underrepresented in registration studies. And unfortunately, this continues to this day amongst many of the studies that we look at. In fact, our unit contributes all the pregnancies and the women to these registration studies when we actually do them. PMTCT is an issue, and there's a continual concern that you need viral suppression, complete viral suppression for PMTCT to be effective. You don't want that baby to end up positive. There's the teratogenicity issues. There's continual concern that, will that baby be okay in terms of exposure to these new drugs? And between these toxicity issues and efficacy issues, the continual concern is, are you overreacting? Are you stopping pregnant women or women in general from having access to effective drugs because you're over-worrying about the baby? So there's this constant tension between concern for the woman's safety and concern for the baby's safety versus keeping new drugs away from women. And this tension is often, you see it in the guidelines meetings when you're sitting and having these discussions. And part of the problem is that the pregnancy registries are one of those things people talk a lot about, but there's very little support for. And there's traditionally been very little support for pregnancy registries going forward, and very little support actually for proper pregnancy studies. And for instance, the Tsepamo study in Botswana, which is really an amazing study, there are very few similar studies, or in fact, I can't think of any other studies quite like it, which have prospectively looked at pregnancy outcomes with new drug introductions, such as the dolutegravir regimens. And the problem with that is that we can't rely on pregnancy data like that with the introduction of new drug classes, such as the long-acting ones. So towards the end of 2021, there was a very strong push internationally to make sure that women are more included in registration studies. And you're going to see lots of angry activists standing up as things open up at the registration studies. So when drug companies unveil their data on their new drug studies, you start to see it in Mexico, people who stand up and say, why are there not more black people and why are there not more women in your studies? So there's a lot more anger being focused on drug companies, not just in HIV, but beyond this, saying why your registration study is not more representative of the people who are actually taking your tablets. Hepatitis B is an issue, and it's a complicated issue because the vaccination programs outside of Botswana and South Africa are very, very poor. South Africa actually has a very good program, and hepatitis B in adult populations was introduced in sort of the late 80s. So anyone born in 90s onwards pretty much doesn't have hepatitis B, but it's common in the adult populations we're dealing with still, sort of people in their 30s and 40s who have HIV. But in the rest of Africa, vaccination for hepatitis B is generally very, very poor. And it's a very common virus, as all of you know. And because of that, you can see that, for instance, in my program, in the L population in the clinics, that's about 7 to 8% of the patients have hepatitis B, but it can go as high as 60% in places in Mozambique. And I'd love to hear in your clinics what those percentage prevalence is. And we also have the Delta virus, which is very difficult to diagnose. So hepatitis B is, you get treatment with tenofovir for free. So to get rid of tenofovir is often a very difficult discussion when you're talking about dual therapy, dropping it and saying we're just going to use the dolutegravir and 3TC. Screening for hepatitis B is very complicated, and we know screening just for creatinine to get for tenofovir often doesn't happen, even in places where we've got really good clinical oversight. My experience has been that that's not well done. I'm not convinced that hepatitis B screening is going to be done any better. So it's very compelling to retain tenofovir and TAF simply to keep the cover for hepatitis B. The problem is that for those long-actings, none of them have any hepatitis B cover. The minute you start thinking about long-acting orals or injectables, you lose your hepatitis cover. You can't use tenofovir or TAF in any of those formulations. There is some science, and some of the drug companies are looking at long-acting forms of tenofovir and TAF, but it's very far in the future. And like most of these drugs, they probably are going to fail. But there's a huge possibility that that free hepatitis B ride we've had so far is not actually going to be held. If it's omitted, it's likely that the B screening will be a prerequisite for us, or we're going to lose that free ride going forward. And we're going to have to make our peace with that. So this gatekeeping of hepatitis B is probably going to fall by the wayside as we go. And to my mind, actually, we might have to make our peace with that, or start thinking more creatively about how we deal with hepatitis B than simply saying, you just have to keep TAF or tenofovir. So we might have a situation where we have to look at that. TB is an interesting one because we all know that rifampicin is this incredibly potent drug interactor. And the problem is that with all these long-actings, every single one of them, pretty much, you have a terrible drug interaction. You can't use them with rifampicin. So the dual drug regimens, you're just not going to be able to use them with TB. But the thing about TB is that it's only a tiny proportion of first-line patients who actually have TB anymore. And perhaps what we just do is the patients who don't have TB go onto the dual drug long-acting formulations as we go forward. And those with TB, they get their efavirenz-based regimen or their double-dose dolutegravir regimen. In South Africa, less than 1% of the patients on first-line therapy have TB. I don't understand why the other 99% of patients need to have it. There are program issues around dual therapy and around the long-acting regimens, and I do worry that in the chaos of service delivery, even in well-run programs, that these drugs might have all sorts of problems. And we're going to hear in the next talk about some of the resistance issues that we might be followed. With the injectables and with even the long-acting orals, what happens if the patients don't come back? What are we going to see with that? What about the training issues? With the transition to dolutegravir, where we were supposed to have a viral load in the South African program, the patients just went across. With even the transition to tenofovir from D4T, we were supposed to have creatinine monitoring, the patients just moved across. With training for injectables and implantables, those nurses and pharmacists and community healthcare workers who are going to have to administer those injectables, are they going to get trained sufficiently? And we're going to have to think about that. Are the patients going to be followed up who fall off the program? Are there going to be adherence? I have no experience with adherence to weekly tablets or to monthly injections or to monthly tablets. The psychologists do, the psychiatrists do, where they use these tablets and they use these injections and things. Maybe we need to go and ask some advice from the contraceptive people in terms of how to use this stuff. And how will patients react to this, to remembering how to take these things? Will we get benefits in terms of handing out smaller amounts of these tablets in smaller tubs? Will there be cold chain problems? I think COVID vaccines have taught us all about cold chains. And is it worth it, changing daily tablets which are working very, very well to long-acting tablets and long-acting injectables? There are lots of cost issues, which is obviously a major consideration for our governments and for our donors. Will the generics come to the party? Will the registration process happen? All this boring stuff that has to happen before we actually get there. Will their volumes go up? Will the costs come down? I was doing some costing work with the Clinton Health people, and it looks like cabotegravir will be at the same cost as PrEP. If that's the case, it does not seem like the cost of injectables for treatment will be the same as the cost of TLD, which is a huge issue for us to think about. Will our governments be okay with a more expensive injectable at the expense of a daily TLD? So, to my mind, the stuff that's really important is going to be around the program issues and women, and the cost probably is going to come into consideration. The final curveball is that the two front runners, which makes us to think about oral dual therapy, islatravir and lenacapavir, have been suspended. Islatravir because of lymphopenia development, so the drug run by Merck, all the drug studies have been suspended. Lenacapavir because of all sorts of administration issues with the glass capsules. So the two big drugs that would have let us have injectables available and orals have been put on suspension. So they are on ongoing pause, so it's going to be a couple of years before we have these injectables. So my final thoughts on dual therapy and long-actings in general is that they're hugely exciting, but TLD is likely to remain the benchmark for oral therapy for a while. But this new era is looming, and we need to start thinking about it. This pause on injectables is forcing us to relook at tenofovir and TAF and whether we keep it. But we need to be thinking about this reliance on TLD, and do we need it? Do we keep it? How are we going to change the way that we do things? And we must not underestimate the programmatic things we're going to be facing. We can start thinking about this stuff. Do we do weekly tablets? How are we going to handle the injectables? And finally, the delivery venues for injectables. If we need somebody to be administering them, do we have to have them within the clinics? Do we put them in pharmacies? Do we administer them at people's homes? We need to start creatively thinking about these things over the next 2 to 3 years, or we're going to be caught on the back foot again in the future. Thank you very much.